Welcome everyone to today's webinar. I am Becky Verzak with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. We are thrilled to have Scott Becker, publisher of Becker's Healthcare, here to moderate the question and answer portion. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the recording to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Susan Nedza is Senior Vice President of Clinical Outcomes Management for MPA Healthcare Solutions. Dr. Nedza is board certified in emergency medicine and clinical informatics. She has served as CMO of Region 5 of CMS, as a senior executive at the American Medical Association, and as a health information technology executive. Dr. Nedza is an adjunct assistant professor at the Feinberg School of Medicine at Northwestern University. And Dr. Nedza, I will now turn the floor over to you.
Thanks so much, Becky, and thank you, Scott, for the opportunity to present today, and welcome to all of our guests. Today, my goal is to provide you with some insight into integrating an unscheduled care strategy into your approach to bundled payments as well as other APMs. So just a little bit about MPA Healthcare Solutions. We're an analytic healthcare consultancy, and we really work with a variety of stakeholders in the healthcare environment to support their strategic decision-making with regards to alternative payment models. So the question of the day is, why focus on unscheduled care? Unscheduled and acute care is common. A third of all patient encounters are related to acute care. Emergency departments historically admit over 80% of hospital admissions, and it varies according by region and by hospital, but it does provide a significant portal of entry into hospitals historically. And a large portion of our spending of the U.S. healthcare dollar, about 6% of Medicare Part B spending, is related to emergency medicine services. So I hope that convinces you as to the value in approaching this topic. So we need to rethink about the emergency department. As we've moved into risk-bearing arrangements such as bundled payments or alternative payment models, what and how the emergency department functions in hospitals changes. So where traditionally it had been a revenue generator, it becomes a cost center. Secondly, it is the front door to the hospital and continues to be so from a public perspective, but there are efforts made to return people to the community more often and more appropriately at times than trying to admit them to the hospital. It's a high resource utilization center. Programs such as stroke centers, trauma centers, cardiac centers, and the 24-hour availability of services ensure that there's a high resources available and appropriate resources available to care for acute unscheduled care. But the challenge now in alternative payment models is to standardize the care and to make it appropriate for the patients that we'll be caring for. And finally, emergency physicians in our departments tend to often look at ourselves as an isolated decision-making unit. Either there's a lack of information about the patients, the attending physician may not be available, and quite frequently that allows the emergency department physician and requires that you make decisions without input or without the ability to integrate and obtain follow-up for your patients. So it's moving to being an integrated decision-making unit within the hospital. Although today I'm specifically discussing the emergency department, the lessons learned apply to other sites of unscheduled care as well. This is especially important as we talk about out-of-network costs in the post-acute care period that will be included in a bundle and are included in risk-bearing contracts. So minute clinics, you'll see freestanding emergency departments, which are proliferating across the country, as well as outpatient or urgent care centers, all take care of patients for unscheduled care and need to be managed as well. I want to give a shout out, if you will, to Dr. Dennis O'Leary, the former president of the Joint Commission. When we were facing some issues related to emergency department crowding, Dennis remarked on the fact that emergency departments are like canaries in a coal mine. It's a place where you can sense the unexpected consequences of healthcare decisions that occur at the community level. That's very true for when we think about bundled payments. For instance, the CMS Bundled Payment for Care Improvement Initiative, the initial review by the Lewin Group of that program found a number of things that most likely won't be surprising to those of you who have participated or care for orthopedic patients. The first is that there's a shorter length of stay. People are discharged to various different locations more quickly, and there's been a remarkable move from the skilled nursing facilities to home health. The cost of the device still remains a driver, and you're saving off discounted rate based on prior services. They also identified a statistically significant increase in ED visits for this particular bundle, and most likely believe that it was related to both the move from SNF to home health and the shorter length of stay. So where are your bundled eligible patients? It's 3 a.m., and at 3 a.m. there aren't a lot of options. I've used this particular slide to illustrate the fact that many of us don't know what your post-discharge death rate is. When we talk about CMS bundled payments, they are not including patients who died during the bundle. However, when we look at the quality metrics that are being used in these programs, death within 30 days and sometimes 90 days is also included. And many times you don't know when patients have died, especially if they're taken to a different emergency department. Or could they be here? This is a typical emergency department with a lot of different people waiting. And this can be a patient dissatisfier. And in these bundled payment models where patient satisfaction comes into the equation, there's a reason to manage the expectations around unscheduled care as well. Or is your patient here? Did you send them to a SNF that has dogs visit? You know, dogs are great for everybody's morale, but if one of your patients trips over this, they're going to be in an ambulance coming back to the hospital. And you want to begin to think about what kind of ambulance will be transporting them into where. We'll approach that subject a bit later. Or finally, did this patient you send home instead of off to rehab fall 2 days after discharge? Patients who were unstable and suffered a fractured hip that resulted in surgery often are unstable after discharge as well. And fall-proofing the house is one of the concepts that we need to adopt. Or they may be in either of these two locations that I've previously referred to. So let's look at emergency care within a bundled payment model specifically. We're going to talk about joint replacement as an example today. The conventional approach to unscheduled care is to avoid it. We want to diminish our emergency department visits. We don't want people to be admitted. We want to limit imaging in the emergency department. And when patients are admitted, we try to prevent admissions to the ICU. All of these are potential strategies that have been implemented in various locations, but may not be the most efficient or effective for your patients. So let's think about the ED and how it manages risk. So the new way to think about this is when you integrate the emergency department into your AAPM strategy, they can help you manage 6 different kinds of risks that are in alternative payments. The first and the easiest, of course, is clinical risk. So patients go home, experience unexpected side effects or unexpected need for care. Their providers are not available or it's the most appropriate site. So they can help manage that particular type of risk. They can also help you manage financial risk. An early visit to an emergency department for an infection may preclude a later readmission. Utility risk, patient decision-making. Your patients will often decide to go to a different emergency department than the one at the hospital where they had their surgery. This can lead to admissions and other expenses that you may not be able to manage and you will be held responsible for. Medical liability risk, we'll touch upon that. Reputational risk, so a poor emergency department experience will impact the patient's ratings of your facility as they are included in any of these alternative payment models, be they public or private. And of course, there's always regulatory risk and not following things appropriately. So let's think about the continuum of risk for unscheduled care. So emergency department utilization ebbs and flows throughout a bundle. There's the pre-procedure time period, which can vary by the bundle, but typically when we evaluate this, we look at it as 30 days prior to the procedure. There's the short-term period after discharge, and for many patients, that'll be the last encounter with the acute care system. The ED discharge, so if they do visit the emergency department, there is another change in their status. And finally, and unfortunately, many patients will make a second ED visit during the bundle time period. Each of these points provides a healthcare system an opportunity to reassess the risk of the patient for these patients, and we'll speak to that in 4 specific domains. So when we look at a collaborative model, this is a model that drives physician engagement, and all 4 areas that I've spoken about previously, emergency medicine can play a role and can coordinate care or serve as a backup for other physicians that are engaged in your programs. Helps to drive physician engagement in the continuum of care. So what we're going to do is begin by understanding the pre-procedure utilization, and then we'll go through a typical post-discharge bundle pattern for patients undergoing joint replacement. Most of the data that I'm sharing with you today is associated with an article that I authored along with my colleagues here at MPA that was published in Academic Emergency Medicine last month. It's a retrospective study looking at potential patients who would be potentially enrolled in a bundled payment program. The data was based on CMS MedPAR data and outpatient files. The importance of using CMS data is we were able to look at admissions and emergency department visits outside of the hospital where they receive their services. And you'll see the importance of that as we go through the presentation. We looked at total joint replacement, and we followed the Medicare criteria in the CJR program in order to mimic and to identify patients who would have been eligible. And our goal was to ask the question, what was the pattern of ED utilization for patients who would have been eligible for inclusion in the CJR program? There's one additional point I'd like to make here, is that when we talk about Medicare, we're also including beneficiaries under the age of 65, those that are the disabled, blind, and qualify for Medicare, and they act as a different population. So let's talk about the population. We looked at 3 cohorts within the study. The first were those patients that had a total hip replacement that was emergent. So these are patients that would have suffered a fractured hip. The second group are your elective patients for the total hip replacement. And finally, patients who had an elective total knee replacement. And when we looked at the patients undergoing hip replacement, we identified a number of differences between your elective and emergent populations. This is very important when facing any number of the CMS and private payer bundles that choose to roll up or to include both emergent and elective patients within the same bundle because they do act as different populations, and we'll see that they have different patterns of post-acute care utilization. So the results of the study, when we looked at 2 years of data, we saw for patients with total hip replacement that was emergent, we saw a 28.4% rate of visits for patients to the ED. There were 10.5% of these visits occurred in the first 7 days. And I want you to keep that in mind because we're going to come back to that fact in a little bit. For the total elective hip replacement, as you can imagine, it's a different population. They didn't have an acute surgery. You had time to stabilize them or optimize their function prior to surgery. They still had a 15.9% ED visit rate. And finally, for your total knee replacement patients, again, elective, the rate was a bit higher. And in these latter 2 cases, the percentage of visits in the first 7 days were higher. And we've hypothesized that that's most likely due to the fact that these patients have gone home as opposed to being in a SNF, which can manage some of the post-acute care for these patients. So when we look at the pre-procedure utilization in the emergency department, what we're focused on is recognizing chronic conditions that require management. and may impact the patient's care. So this is pre-procedural clinical and financial risk. These are things such as the utilization rate, what the diagnosis was for those visits, and to identify conditions likely to be destabilized due to a specific procedure, and also to look at demographics. When we went and looked at 3 years of Medicare data and looked at almost 280,000 cases of hip replacement, so this is both patients with emergent and with elective hip replacement. This slide illustrates the pattern of emergency department utilization in the 30 days prior to surgery. This isn't something that most bundles take into consideration, and it's an area where there's a lot of great information that gives you a sense of risk that you're going to need to be able to manage. And so, for instance, you'll see that musculoskeletal complaints are high on the list. This includes falls. One of the things we identified isn't surprising was that patients who fell prior to their fractured hip surgery would fall again within 90 days of post-discharge. And there's also an opportunity for prevention in that particular group. Injury, trauma, cardiopulmonary, the usual types of things that I, as an emergency physician, find pretty regularly in the Medicare population. And things such as physiologic decompensation, syncope, dehydration, anemia, that in the acute hip fracture patient, you don't have much time to stabilize, but that will leave the potential to be destabilized during an acute surgical procedure. And just as a reminder, we did not include the ED visits associated with an admission for a hip fracture. So these are all visits that occurred prior to the day where the bundle was initiated. In addition, these are cases where they could have been discharged home or been admitted to the hospital. Other work that MPA has done has identified this as a risk factor when we develop risk equations for managing these patients and predicting their length of stay and adverse outcomes. Then patients go home or they're discharged to different settings. The second step is to identify ED utilization within 7 days of discharge. We don't use days from procedure, which is quite common in performance measurements. We prefer to use from the time of discharge because it gives us an opportunity to look at what's happening in that particular time on the continuum of care. And it varies how many days you're in the hospital post-procedure. So this seems to be and has worked well as we've developed our predictive models. So in this area, there's two places for potential intervention. One is recognizing that there may be clinical conditions that were either destabilized during the hospitalization or that need to be evaluated prior to discharge. This is important when you think of who is making the discharge decision. If it's the orthopedic surgeon, they may be, or their PA or advanced practice nurse, they may be looking at the orthopedic conditions, but may or may not have real insight into other conditions that are likely to be destabilized and the likelihood of an emergency department visit. The second is patients. When we think of utility risk, this is the idea that patients make decisions based on personal utility. So if they live far away and they've come to a joint center, they most likely, if they have an unscheduled care need, will end up at another location. There's also the possibility that the surgeons may not be available or others. This is the role where the care navigators come in, and not only explaining to patients that it may not be appropriate to go to the emergency department first, but providing an input to maintain their connectivity to your system when they do need unscheduled care. So let's look at some patterns. This slide shows the number of ED visits by hip replacement. So again, it's both cohorts, 1 to 7 days post-discharge by a discharge diagnosis group. And you'll see that this is a larger cohort. Again, we're using the CMS data. And I think everyone will be struck by the number of patients that come in between 1 and 3 days and the frequency of the things that they come in for. So physiologic decompensation, the hemoglobin of 7 is now the new 8 for any of you who are involved in the discharge process. And when patients go home with a hemoglobin of 7 and they're 80 years old, they can get dizzy. They can become dehydrated if they're taking pain medication. So it's not surprising that the first and the highest group, the highest utilization is for things that are directly related to decompensation associated with either the surgical procedure or with destabilization of their prior medical conditions. Musculoskeletal comes second, and then you'll see as we go down the list any number of other categories. So what were the discharge diagnoses from the emergency department for these patients? If we look at the patients who had an elective hip replacement, we're looking at the Texas data. In the first 7 days, patients with elective hip replacement had pneumonia, a dislocated prosthetic joint, septicemia, aftercare following joint replacement, or a hematoma that was procedural related. I think most everyone would agree that these were appropriate emergency department visits. What also is striking is a number of things that are related to the surgery and quality of the surgery, as well as conditions that we would mainly consider hospital acquired that may not have been diagnosed in the hospital but manifest themselves after discharge. Thinking back to that early discharge, we're seeing fewer hospital acquired conditions, and that may be partly related to the fact that we're discharging patients sooner and these infections are showing up later. A little bit of a difference in the hip replacement patient. Remember, they're older, they may be more debilitated, and you begin to see things like aspiration pneumonia, UTI, and fever. And again, the anemia also comes into the picture. And so it goes. The knee replacement patient, syncope and collapse is one of the ones that is different in this particular group. The other thing we identified was that for these patients, we know what their total number of episodes were and how many chose to go to different emergency departments. Even in your knee replacement patients who are elective cases and you have an opportunity to do education, 28.4% of this cohort chose to go into an emergency department other than the one where they were operated on. Now, they may be in your system, and again, we're not capturing other visits such as to an urgent care or to a freestanding emergency department, but I think you can get a sense of the potential financial ramifications of this, especially if they're admitted elsewhere, or if you need to absorb transfer costs by putting them in an ambulance that will be counted in the bundle price. And you don't know when this utilization is going to occur. This is also the reason that we advocate using as much data as you can related to emergency department and other unscheduled care visits outside of your system when it's available. So the third step is to identify ED utilization patterns within 30 days of discharge. So we've spoken about the pre-surgical period. We've now talked about the 7 days that in some cases used to be days when you were in the hospital. So they're things that we might have seen on the inpatient wards in the past, but are now occurring either in the SNF, the rehab, or in the home health setting. And now we're moving on to the third phase. So these are, within 30 days of discharge. And there are many that would argue that this is the appropriate time to end a bundle, because this is the point where, you think that any visits after this will not be related to the surgery. And we'll approach the answer to that question when we look at the next area. The kind of risk that you're talking about in the third bundle are, again, these variations in discharge dispositions. What's the risk? They've been at home. There's all kinds of things that have happened, or they've been in a SNF and they may have, been exposed to different bacteria that are in the SNF. And then, so the risk pattern changes. So it's not the same risk that they had prior to surgery or even at the time of discharge. They're also at risk for advanced imaging. Now, advanced imaging is appropriate. It's certainly something that I, as an emergency physician, and my colleagues use regularly, but it is something that drives additional cost into an urgent care situation. And it also speaks to the need to integrate with outpatient providers. You may think that if patients, we often focus on that first visit with, some type of healthcare provider to do a medication reconciliation or a visit within a few days, but that risk doesn't go away after that visit. The data that I'm going to show you illustrates the fact that they continue to need close monitoring and intervention at times with their healthcare providers. And there's a key question here that we need to ask when we're talking about discharge dispositions in this time period. And it's really a paradigm shift. We generally will look at these patients as emergency physicians, and the question asked is, do they meet admission criteria? I would put forth that that's not the appropriate question for us to be asking. It makes sense from a payment perspective. But as a physician, I tend to look at this as, what is the likelihood of an adverse outcome if I discharge this patient? Because the reality is most patients want to go home. But at times, there is a risk associated with that discharge. Here you have the 30-day, the most common diagnoses that we found within 30 days for an emergency department visit. I won't walk through all of them because it's a similar model to what we've seen before, but it really speaks to things that continue to be related to the hospitalization. Post-discharge pain continues to occur. Constipation will also be seen because we're using pain medications for these patients, and abdominal pain and GI is not an uncommon reason for the visit. And in an elderly patient with abdominal pain, constipation is the last thing we generally think about. We think about a lot of other things, and so they will be visiting the emergency department and discharged with a diagnosis of constipation. Ongoing monitoring for UTI. We've done a great job of removing catheters in the hospital to avoid hospital-acquired infections, but there is a propensity for these patients to have a UTI, and they did have one during surgery in many cases. So monitoring for that particular diagnosis is critical. Things like fall-proofing the home, because we do see patients coming in with swelling or contusions related to falls. And finally, looking not only at the risk of infection of things like UTI, but just post-discharge infection monitoring overall. Speaking of the discharge disposition, this is another area where we see variation. When we look at emergency departments across the country for the same group of patients, we see, and this is risk-adjusted patients, there are variations in the utilization of discharge versus being admitted. We're seeing an increase in observation stays across the board. CMS is aware of this, and if anyone's following the new cardiac bundles, there is a metric that has been integrated into the scoring for whether or not you make the cutoff for a reconciliation payment that looks at excess hospital days. So that includes, this is days not in the readmission, but these are days associated with emergency department visits or observation stays. So the shift to observation to avoid a readmission in that particular population, and this metric that CMS has recently put forward, will also impact our ability to observe patients in those groups. Transfer rates, and we look at discharge to SNF as another common discharge, which in most cases we are not allowed to admit directly to SNFs, although with the waivers that are in place in many of the bundled payments, there is an opportunity to discharge directly to SNF from the emergency department if you're utilizing social services to support that. This slide also, one of the things it does not speak to, one of the limitations of this particular analysis is we didn't look at time of day, because time of day really does make a difference. It makes a difference for social service, for coordination, and for some organizations have decided to include a social service coordinator on the night shift, not on the day shift where it's easier to put somebody, but on the night shift when it's much more difficult to discharge an elderly patient home alone. But we have to be careful. When speaking to an emergency department colleague, he admitted the fact that he doesn't really know what happens to his patients and what the real risks are of discharge home. We all would come in on the shift the next day and people would say, remember that patient you saw, either they died or they got readmitted. But in fact, if that was a rare occasion. So we really don't know if patients go home and die. If our diagnosis was correct, were they readmitted to another facility? What was the cost of an outpatient workup that was undertaken as opposed to an admission? And I'm currently involved in some research to look at that. And then also, were they ever seen by their doctor? It's amazing to see how many times we would say be seen in 1 or 2 days. and in fact, the patients never make that appointment for a number of reasons. There was a recent study by a group from Harvard that was published in the British Medical Journal looking at risk of death within 7 days of discharge. And these particular patients, they looked at a number of different conditions on the ED claim and then used that to compare to death certificate information. There's a number of problems with the study, but because death certificates have been found to be less than accurate in many, many cases. But this is really one of the first times in recent efforts to look at what the diagnoses were associated with risk of post-discharge death within 7 days. So what made the list? Altered mental status, number one. And you'll see if you look at, as we go down, these are listed in frequency, that those particular diagnoses that are more symptoms than an actual diagnosis. So the patient came in with altered mental status and they had a CT scan and a bleed was ruled out. They still have altered mental status. We have looked at those particular patients and said, they don't have a life-threatening condition, they can go home. But we haven't diagnosed, in some cases, what their altered mental status was related to. Same thing with dyspnea. We can say it wasn't a PE, there was a CT scan of the chest done. And you'll go down the list to see more of these generalized complaints, such as malaise, fatigue, sometimes known as generalized weakness and dizziness in the emergency department, but ICD-9, malaise and fatigue, nausea, vomiting, and then some of the more chronic diseases where you do see changes. And I wanted to share this today because this is an area where if we're going to be focused on return to the community, we need much better data about what happens to patients related to their emergency department visits. And it will also inform the use of tools, risk-based tools that will help determine the appropriate discharge location. So the final phase is to look at what are these improvement opportunities that we have? What can we do in the emergency department or with acute care to make care more efficient and effective? So when we talk about efficient, we want to make sure it's high quality. And when we talk about effective, we're discussing specifically managing cost. So back to our cohort of patients from CMS who we've been visiting with. The number of visits by patients, again, we're talking about the hip replacement patients. What we're comparing here is the number of patients. We're looking at pre-emergency department utilization and post-emergency department utilization out to 89 days post-discharge. So what you'll see is that what we saw in the first slide, there is an intrinsic pattern of utilization for patients related to either to chronic conditions that they have that occur prior to their study or their surgery. And if they are seen in an emergency department in the post-discharge period, and as we go out to 90 days, which is quite frequent in bundles, especially in the CMS bundles, there's continued utilization. That some of us have returned to baseline, but when we look at the diagnoses, they're a bit different. And I'll call your attention to neuropsych specifically. We do not always do a good job in the healthcare system of identifying what happens to elderly patients who undergo procedures. They've had anesthesia, they've been disrupted, and it is not unusual to have them come back to the emergency department for things, especially this is again the altered mental status, or even paranoia associated with pain medications. They're a pretty fragile population. We also see that the injury trauma line continues to be high, and that is related to the fact in many cases, you've had a surgery either because you were unstable or you may have some instability in your gait post-operatively. So it calls into question whether or not patients are having appropriate and enough PT and are living in an environment where they're not at risk for additional falls. Because when we look at the diagnoses that occur related to these visits, there are, similarly, we continue to see the dislocated prosthetic joint. So it doesn't just happen in the first 7 days, but can happen after that. Chest pain comes back in a higher level in 2 of the groups. And we see things like open wound of the scalp, which is related to falls. And again, the infection rate continues. So as we think about this from a physiologic perspective, the disruption to the human biome, if you want to call it, or the homeostatic level of function of individuals continues beyond 30 days. So that when we look at potentially risk adjusting or reevaluating risk for these patients, we need to do it at multiple times in the post-discharge period, because clearly what you're seeing here is not something that may have been predicted at the time they were admitted to the hospital, but can also be impacted by events during the post-discharge period. I'm going to shift for just a couple more minutes and talk a little bit about costs. We won't spend a lot of time in this slide, and you'll be able to access this information post webinar. But there are different, not surprising, the costs associated with different discharge dispositions occur. And I think that this speaks to the fact that observation stays continue to be a good option. However, the price of those is going up. And then there are Part B charges associated with these patients as well. And when we look at their costs within the emergency department, additional consults, the radiology component for advanced imaging can add into the Part B costs, which then again will be included in the bundle payment. Don't forget about ambulances, even in elective knee replacement. ALS ambulances are used quite frequently, so those are advanced life support. And not surprising, because when you see what these patients came back for, many cases they came back by ambulance, and plus they just had surgery and they may not be able to move, or they're in a SNF. And so for the acute utilization, it differs across the three populations, but it is an area that many of us don't recognize that we have opportunities to impact. The idea that when patients come into the emergency department for care, they may or may not necessarily need to go back by ambulance to where they came from. So there are opportunities, even in the acute care setting, to save on ground transportation. That goes for non-emergent transportation as well. I happened to be in my orthopedic surgeon's office earlier in this week, and paramedics wheeled in a patient who was clearly it had trauma, and was there for an outpatient office visit. So money was saved specific to that, that outpatient visit, but one might want to ask, why is it that the orthopedic surgeon wasn't making rounds in the SNF? Why did they not go to where the patient was? Because you look at the cost of transporting that patient, which is a Part B cost, to the orthopedic surgeon's clinic or to the SNF, or I'm sorry, to a imaging center, and those dollars add up as well. So let me conclude by just bringing up the point about, will your bundle strategy be dead on arrival like our poor canary here? In the first year of bundles, and this was both in the first year of BPCI and the second year of BPCI at the CMS level, and also we're waiting for results of the CJR, but many of the initial savings in that first year are one-time savings. You can manage the joint replacement, or the joint choice that your orthopedic surgeons are making, or you can optimize certain inpatient procedures and discharge patients early with, again, the risk of that discharge occurring. But you need a strategy in year 2 and 3. And this also goes for your accountable care organization participation and other advanced payment models. And as physicians are driven by the macro legislation to participate in AAPMs, integrating an emergency department strategy or an unscheduled care strategy is a winner for those physicians, as well as for the organization, the hospital or health system that's sponsoring the risk program.
Dr. Nesda?
Yes.
It's just a terrific presentation. Let me let you keep going. I didn't mean to cut you off. I wasn't sure if you were ready for questions or had a couple more slides.
I have 2, so we'll finish in just a moment.
Go right ahead. I'm so sorry. Thank you.
Oh, that's okay. I took a breath, I took a breath.
We've got some great questions from the audience after you get to these slides. One of them is, will you send out this fabulous presentation? So that's a very complimentary question. But go ahead with the last couple slides, and then we'll get to questions and answers. I've got a bunch of them.
Sure. So the next photo is some of my colleagues at Northwestern who are seeing a patient late in the evening. And again, you've got a team of people there that if you work closely with them, they can manage the cost of the visit, manage utilization, and in many cases provide a rescue service, very similar to what you see the group on the left doing. This is a group of coal miners who go into coal mines and rescue people as well. So adding a module or a strategy related to rescue care is an important strategy. And finally, as I've touched upon throughout the presentation and here towards the end, your goal is sustainability. And so the efforts that you make related to AAPMs and to bundled payments and integration of a strategy to manage unscheduled care will pay off in multiple different ways. It'll be across different payers. It may free up capacity in your emergency department. It may allow you to utilize alternative sites of care for these patients that are appropriate, and it'll help you to manage leakage when you're being held responsible for care that occurs after a patient has left the four walls of the hospital. So I leave you with I always like to leave people with what you do next. So first of all, yes, the slides will be distributed. Look at the perspective on the challenges and review your own ED data, and especially that pre-procedure emergency department use. There's a lot of value there. Identifying your cost savings related to this. Bring your emergency department providers, be they employees or a contract group or a group that's hospital-based, into the discussion, and use bundled payment opportunities for gain sharing to include them. If they're driving a lot of costs in the post-discharge period, there's an opportunity, if you align financial incentives or even risk in an ED contract, to drive improvements in your ability to gain in these programs. Risk management is really important. I'm always surprised when I see people trying to do this without risk adjusting the patient populations. It's important to do it, as I mentioned throughout the presentation, across the continuum of care, and to identify which adverse outcomes you're looking at. And emergency departments, again, can help you identify things that happen because of early discharge. So precision risk management and risk stratification across all of the bundle is critical. And finally, as always, monitoring your performance to track efficiency and effectiveness, because there's always unexpected consequences. If there's something I learned at CMS was that we generally would put things in place and we didn't have a feedback mechanism. But that doesn't mean that those participating in CMS programs cannot collect that information and provide it back into the healthcare system, which we're changing very rapidly, and as some people would say, changing the tires on the car as it goes down the road. So I'll finish there, Scott, and look forward to the questions.
Great, Susan. Thank you so much. I know we've got a couple very complimentary comments, and then I wanted to ask you a couple questions, and then I'll get further into some of the audience questions, which we now have a bunch of them. The first question I had, sort of the most interesting thing that you found in sort of overseeing and studying this issue of bundled payments and what's going on with hips and knees and so forth. I saw some of the distinction between hips and knees where they're elective versus non-elective, but a couple just your most interesting observations so far.
I think the heterogeneity of patients in a bundle, and this carries over to the new cardiac bundles, that, as we know, they're on hold as the new administration's evaluating whether or not they're going to make them mandatory. The preliminary work that we've been involved in really has identified variations in not only the risk among the population, so those that have a PCI, or let's just say that have a STEMI infarct, so they are identified right away as having a heart attack by EKG, versus those that are admitted for, say, syncope and end up 4 days later having a cath and then having bypass surgery. So the first place that we look at, and which really is important for both the hips and for other bundles, is to try to break the population down.
In terms of the difference in the patients, the heterogeneity of them, how do you address that efficiently? Is there a way to address that efficiently so you could plan efficiently around them? Because the more that they're each different, the more customized it seems the care has to be. Any comments on that? I
think if one particular point would be when patients are going to be evaluated for elective surgery, identifying their pre-surgical ED utilization pattern. Questions such as, have you been in an emergency department in the last 30 days, either admitted or discharged? And understanding what that condition was. That's a commonality across all of these groups. It's across every bundle. If someone's accessed acute care in the time period prior to an elective surgery for something that's related or unrelated, it's going to have an impact. And that, again, is something that you're going to do across all of the bundles. So putting that type of question into your pre-surgical screening, I think will pay off very, very well for hospitals.
In terms of patient selection, you recognize up front that here's a patient who's been a heavy user of ED, of the emergency department. Is there a way to not take that patient in the bundle, or are you largely stuck with that patient regardless?
It depends on the who you're working with. So in CMS, the answer is no. But when we look at private payers, you maybe want to put that into the pricing strategy. So for instance, when we're working with prospective bundles, for groups that have high risk, the price that's set at the beginning of the bundle takes that into consideration. Because you don't want to take out all your patients that have risk, because if you start a bundle with only the healthiest patients, you don't have a lot of room to improve care. They're not going to have risk that you need to manage, because that's really the game. So we really recommend that you find ways to keep them included, but to address the issues and clinical conditions and social conditions, if you will, that'll impact their post-discharge utilization.
Here's a couple of additional questions from the audience, and I want to come back to you on best practices. Patients that have had an ED visit and return after having a hip done, is there data on how many have had another fall at home or falls at home? That's one question. Then I'm going to ask you a second question, just to have in your mind, about dealing with diabetic patients. Any thoughts on dealing with them? So first is on data on falls, particularly on patients that have had an ED visit post-hip replacement.
I didn't go over some of the findings in the study that I published in March, but many of these patients have like 1.5 visits. So there's repeat visits even in the emergency department. From the fall perspective, yes, that is something that continues to play out across every bundle we've looked at, especially here in the joint bundles. If the person can send me an email that asks the question, I'll be happy to send a response and provide, a link to some of the data behind that. So yes, fall prevention is important. And if you want to talk about a best practice, patients who had an ED visit prior to a joint replacement, or who are even coming in for elective joint replacement, need to have their house fall proofed. It's just, as we send more people home, we need to ensure that they don't have throw rugs and all the other things that are associated with instability. The second question related to diabetics. So, I think it depends on which population you're looking at. Diabetes is interesting because if a patient's diabetes is not well controlled, it isn't so much the diabetes that may or may not be what affects them within the bundle time period. You don't see patients coming back in with hyperosmolar coma, for instance, with very high blood sugars. But it may be an indication of their compliance. And when we see these patients, we tend to, the knee-jerk reaction is to really manage their sugars in the hospital, perhaps to get an endocrinology consult. But in fact, it may be more related to the fact that either they can't afford their medication, which is a problem, or they aren't using it effectively. So this gives us an opportunity to help manage the diabetes, because the number of visits for diabetes, again, as I mentioned, are not going to be driving this. It's usually a comorbidity on some of the other reasons that they come in.
Let me ask you a different question related to any observations on sort of the difference in how this works with females versus males. I've got a more complicated question from the audience, but maybe a few overall thoughts on how these programs look versus predictions on males versus, females.
Females generally are a higher risk, and that may be related to age. It is related to age, I know that for a fact. Living alone, because remember, women out-survive their husbands or are living alone more frequently. So there are other factors associated with being a female that drive some of that risk. So yes, that's a group that you might want to, they also may have osteoporosis as compared to the men. So that if they do fall post-operatively or unstable, they're more likely to come back with the wrist fracture than the man is who does not have osteoporosis and does not suffer the wrist fracture. So I think those are three examples of where the gender impacts risk.
Gotcha. A few other questions about best practices. Any best practices in utilizing to determine if a patient is a good candidate for surgery or not as it relates to scheduled surgeries for hips and knees? Any sort of starting point on best practices? And then the second question I'm going to get to is, how do hospitals go about developing standardized practices for some of the things you're talking about that are sort of not traditional medical, sort of fall-proofing the home or advice on those kinds of things? And so the questions around best practices, one is on selection criteria. And let me let you start there, Susan, if you can.
So there's some things that have been identified. Certainly, obesity, having over 5. There are many centers that are doing joint replacement that will hold off and work with the patient to, impact their weight prior to surgery, because that has a number of issues related to it. I think more focus on acute decompensation of chronic diseases if they have them prior to scheduling. We pass, you may say, have you had, CHF, heart failure? Have you had, a fall? Different things, but it's different if you ask if that particular condition or event drove you to use an emergency department in the 90 days prior to the surgery. So if there's any when screening the patient up front for appropriate surgery, those kind of questions not only can say, hey, that can be a red flag, certainly, but more importantly, it can help you define how you're going to manage them during the care. So if you do decide to go forward, this gets your fall-proofing the home thing. Even the CMS bundle allows for additional visits by non-home health certified individuals, using that opportunity to go into the home. And, there's great fall checklists out there. There are some communities that are actually using paramedics to do that because the patients will answer the door if a paramedic comes to the door, and you've got your fire department in the neighborhood, and they're good at working with the population. So, again, recognizing, the acuity of any of their chronic conditions, and certain chronic conditions, if you want to think about a red flag that may indicate, additional comorbidity or additional cost, would be things like a recent fall, because people will. I think hopefully
Got it. No, that's very helpful, particularly things that have been recent problems, recent episodes the patients have are particular predictors, it sounds like. And then, Dr. Nesda, one best practice for hospitals, like one or two best practices you would say in sort of implementing a bundled program. And then I want to ask one more question on emergency department integration.
Okay, so we'll leave integration out because that's just mandatory. I'm not going to call it a best practice. The first is this idea of preoperatively understanding what their acute care utilization has been. That, I think, will reap all kinds of benefits. The second is, at the time of discharge, looking at appropriateness of site of care as based on conditions that occurred during the stay. So they may be stable to go home, when we think about, they're doing well from the surgery, they don't have any abnormal labs. But for the patient who has a history of a cardiac or a respiratory condition, that is the best practice is that they get managed very closely for those in the 30 days post-discharge. Not just, see your doctor, that there is a concerted effort to manage those chronic conditions, because I think everyone saw in the slides, they result in any number of visits back. So that's my two best practices.
Got it. And working with a contract management group, a contracted managing group in the ER. So a group that's not employed by the hospital, but one of the third party, and they're so prevalent, ER groups. Any best thoughts on making sure that they are on board with you in these practices?
Yeah, I think the benefit of approaching them and working with them is that this can be included in your contracting, that they adopt a certain set of criteria or best practices, if you will, for their physicians, and then you monitor the outcome of that, and you can do it in the financial arrangements. So you can either include them in a gain share, which is one option, but the other is more of a guarantee around the use of resources within the emergency department and management post-discharge. I would also add that you can, through that contracting, use them for some of this management in the first 3 to 7 days post-discharge if you need to. Some of those companies have ambulance programs associated with them. They can help you manage that cost. In addition to that, they can be required or let's just say encouraged to do more in reconnecting with the patients, reconnecting the primary care physicians. Because when we added hospitalists to this model, the primary care physician has really, who's going to be responsible in that 90 days post-discharge for the non-SNF or rehab patients, has been out of the loop. And it's quite frequent for emergency department physicians we don't necessarily call the primary care doc when we send somebody home. So there's some things you can institute with them in the best practice. And then if someone wants to send me an email, we can talk more about what you can do from a financial perspective with contracting groups.
Do you want to note your email address again, just so people have that front and center?
Yes, it's snedza@consultmpa.com.
Great. Great. Susan, just fascinating. I learned more in the last hour about bundle payments than I've learned in the last few years listening in on things. Just everything from the difference amongst patients to hip fracture to elective to knees to gender differences to how much close study of patients up front versus follow-up. Just a fascinating learning experience for me, and I thank you very much. For the audience, if you have follow-up questions for Susan or for MPA, please let MPA know or let us know. We'll make sure we get the right people at MPA to talk with you. And Dr. Nesta, just a terrific presentation. Thank you very much.
Thanks a lot, Scott. It's a pleasure to share knowledge with people who can make a difference for patients, because after all, that's why we're all here. Thank you.
Just terrific and extremely informative. Thank you very much. There's been great comments on the slides. Somebody just wrote, she's been great. That's about you, not me. And so I appreciate the terrific webinar very much. Thank you.
Oh, thank you.
We're going to close out now. Thank you, folks, very much for listening in. Bye, guys.
Okay, bye-bye.